At this time, I'd like to introduce our moderator for today's webcast, Stephen Davidow.
Thank you, Mr. Wyatt. This is Stephen Davidow, Manager of Quality Implementation Programs for the Society of Critical Care Medicine. I want to let you know that today's webcast is supported by a grant from the Agency for Healthcare Research and Quality. The content is solely the responsibility of the presenters and does not necessarily represent the official views of the Agency for Healthcare Research and Quality. It's my pleasure to introduce our speakers today. First, we have Michael, or Mike Jones. He's the Vice President for Research and Technology, the Director of the Virginia C. Crawford Research Institute, the Shepherd Center in Atlanta, Georgia. And then we have Julie Gassaway, who is the Director for Health and Wellness. She is also the Senior Clinical Research Scientist at the Virginia C. Crawford Research Institute at the Shepherd Center in Atlanta, Georgia. And with that, I should also note that our next webcast is entitled Comprehensive Patient-Centered Care in the Pediatric Intensive Care Unit. We'll be hearing from Jason Adler at the Joe DiMaggio Children's Hospital in Hollywood, Florida. And that will be on November 12th. And so with that, I'll turn things over to Mike. Thank you, everybody.
Thanks, Stephen. I hope folks can hear me okay. Yeah. Can't take control. Oh, I got it?
Oh, it's down here.
Oh. Can you do it, or does Steve have to do it?
They told us yesterday we had to do it.
Okay.
Steve, can you hear me?
I can. You can just click on the presentation with your mouse.
Ah.
Oh, I'm sorry. I was clicking on the arrow.
Okay. Hi, folks. Thanks for joining us today. And as you may be able to tell from my voice, this is Mike, not Julie. I'm going to turn it over to Julie shortly. But I thought I'd start by giving you a little bit of background of who we are and the patients that we serve, and try to kind of point out the relevance to those of you who work in critical care. We're assuming that most of you do, in fact, work in the critical care arena. We both work at the Shepherd Center. Shepherd is the largest specialty hospital in the U.S. It's a private nonprofit founded in 1975. And we serve exclusively individuals who've experienced catastrophic neurologic injury or disease. The three primary diagnostic groups we serve are traumatic spinal cord injury, traumatic brain injury, and multiple sclerosis. And on the inpatient side, we admit about, I think this year we'll have about 1,080 newly injured patients with either spinal cord or brain injuries, or both. Probably 200 of those individuals will have both a traumatic spinal cord and brain injury, making their care particularly complicated. All of these folks have significant neurologic damage. We tend to get the worst of the worst. So we're talking about complete spinal cord injury. We have a low-level brain injury program serving folks that are just emerging from coma. So they all have very significant disabilities when they enter the hospital, as well as multiple impairments to their body systems. And many will leave with a lot of those impairments. While we do a great job with recovery and pride ourselves on our success rate in terms of rehabilitation outcomes, the basic fact is that many of these individuals will face lifelong care needs, either in meeting their own care requirements or in managing a personal attendant or other resources to meet those care needs. So I hope that gives you some idea of the complexity of the population that we serve. Most of what we want to talk about today is the impetus for several systems change efforts that we've initiated, focused on patient engagement and really more patient-centered care. And as it has evolved over time, it's really gone from patient-centered to patient-controlled. As Julie will point out, we very much have begun focusing on peer-to-peer support in helping these individuals transition from being a patient in a hospital setting to being a successful citizen in the community. It no longer becomes a care need or is just a function of health care and the supports we can provide. It's really more the supports that individuals living with these conditions in the communities can provide. So a lot of our focus has evolved to more peer-to-peer health care or peer-to-peer support. So let me start by explaining some of the impetus for change. I came to Shepherd in the mid-90s. Throughout the latter half of the 1990s, we saw a pretty dramatic shift here in Atlanta in the lengths of stay for our patients. As managed care made its way across the country, it hit the Southeast in the late 90s, and we saw lengths of stay for inpatient rehab drop from about 6 months in the early 90s to as short as 30 days by the year 2000. Needless to say, the patient needs had not changed. We still had folks who were coming to us, if anything, sicker and quicker in terms of their transition out of trauma care, with significant needs, with need for long-term rehabilitation, but very short period of time to deal with that. And while we could certainly address many of those needs during the inpatient stay, it was clear that patients were leaving in a much more distressed state, both patients and families, in terms of their preparation for discharge. So throughout the late 90s, we experimented with a number of transition support strategies, including the use of telehealth, different telecommunications technologies to support those patients as they transition home and after their return home. And although we're based in Atlanta, we see patients from all over the eastern coast, east of Mississippi, and to date about 50 different foreign countries. So they're not just going home in our community, they're going home to communities all over the country. So that makes the discharge home even more daunting in some respects. Based on that early work, we received funding from a local family, the Marcus family, to support the Marcus Community Bridge program. And I like to characterize it as the Cadillac of programs. It allowed us to send individual staff out into the community, wherever that individual was returning back to, whether that was Alabama, Mississippi, Ohio, Mexico, it really didn't matter. We had dedicated staff who could go out and find the resources and supports that individual might need for a successful transition home. That was supported by, again, the use of telehealth technologies, as well as a lot of online resources that we developed through the years. That was initially a $17.6 million gift, but it was winding down towards the end of 2010, 2011. So that's with looking with what we do from that point forward. This was about the same time that looming contingencies were presented for hospital readmissions. As you know, as a result of the Affordable Care Act, some of the CMS requirements, hospitals are now being held accountable for any readmissions within the 30 days, which while we're licensed as a long-term acute care hospital, nonetheless it's something that we're mightily concerned about with our patients. And a third trend that led really to the impetus to rethink our whole transition support program was kind of the growing sense that patients and families were just not engaged in the rehab process and in preparation for discharge as they should be. Part of that was due to the shorter lengths of stay, but we think, at least anecdotally, a good portion of that too was the kind of emerging focus on neurologic recovery. You know, we hear a lot in the media, in the popular media, about recovery of walking after spinal cord injury, and indeed that's a big focus of rehab here at Shepherd Center. So there's a clear sense for families coming into Shepherd Center and for patients that they're going to walk out of here. And so, you know, there's this kind of this transformation that has to occur, what's referred to in the psychological literature as response shift theory, to really reach a point in time where they understand the importance of some of the things that we're trying to teach, and accept the fact that, in fact, despite our best efforts of rehabilitation, some of their disability and some of the conditions they will have to deal with are going to be permanent. And therefore, it is important that they learn about self-care, self-management of their own disease condition, et cetera. So those are the conditions that led to us to rethink the process. As I mentioned, towards the end of actually 2011 is when we established as a strategic objective to improve patient engagement in the care process with a goal of minimizing hospital readmissions, understanding that our Marcus Bridge funding would likely run out by the middle of 2013. So our directive was to identify systems and strategies that we could do to improve patient engagement while they were here, as well as to better prepare them for discharge, and then fund the money to develop and implement these changes. And over the course of the subsequent year, we were able to successfully receive funding from PCORI, the Patient-Centered Outcomes Research Institute, as well as the Woodruff Foundation, to undertake the changes that we're going to describe today and do the research leading to evaluation and replication of those innovations. We started in terms of examining or identifying possible strategies for improvement, by analyzing our hospital readmissions. And again, thanks to the BRIDGE program, our readmission rates, particularly for very significantly impaired individuals, was quite low. It's never gotten over 10% on a monthly basis and tends to kind of bounce between 5 and 10%, which again, compared to very sick individuals being discharged from hospital, based on the benchmarks we have been able to identify, is actually pretty good. But in looking at reasons for readmissions, they tend to break out into two general areas. Those that occurred very early after injury were due to very specific medical problems, some of which could be identified prior to discharge, and we could do a better job of managing those patients, or a more intensive effort at kind of transitioning those patients home. But some of which were not readily identifiable until the patient got home. Oftentimes these were related to problems with getting medication prescriptions filled, other problems that became emergent in the 24 to 48 hours after discharge. And in those cases, in many respects, the only recourse was for the patient to go to the ER if they were not local, and that oftentimes resulted in a hospital readmission. We also noticed that in terms of later causes for readmission, these tend to be related to care routines and the individual's kind of success in carrying those out over time. And it could be that these were due to caregiver burden, if they were relying upon a caregiver for that assistance, or just not a good job of really strengthening those critical care competencies before they were discharged from Shepherd Center. We also spent an extensive amount of time interviewing and conducting focus groups with patients and families, both current patients who were preparing for discharge, as well as those who had recently, over the last 30 days to 6 months, had been discharged for inpatient rehabilitation. And we made a point of including both happy families, those that had had a very good outcome and very good experience at Shepherd Center, as well as those who were not as satisfied. We did a series, I believe, of 6 focus groups till we reached saturation in terms of the type of information that we were getting back. And some clear trends began to emerge in terms of the areas that we might want to focus on for improvement. First and foremost, patients and families told us that while the training that they received while they were here was essential to success, it was also very overwhelming. We have a very detailed patient and family training program, a lot of time spent in the classroom, but also at bedside, teaching patients in care routines, teaching families all the background information that they may need to really understand traumatic spinal cord injury and its consequences. And clearly it's too much information. As one dad said, it's like just turning on a fire hose. There's so much information we can't possibly grasp everything that's important. And looking at our courses, indeed, they were taught at a very high level. You know, much of the focus was on teaching patients the basic background of, you know, what is a problem with neurologic bladder, why does it occur, et cetera, and helping them have that understanding before they learn how to manage the problem. So with too much information, families and patients urged us to really break it down into smaller chunks and focus on the 2 or 3 most important things they have to master while they're here, and hopefully have the other stuff available once they return home as needed. They also identified the need for more real-world experience, a chance to kind of walk through scenarios here so they really understood how to effectively problem solve once they returned home. A second thing that patients and families told us is that even despite our extensive training and what we felt was fairly detailed preparation, even with the BRIDGE program, they got home in the first 24 to 48 hours were just a nightmare. Their level of comfort and their ability to really do the right thing should an emergency arise was very, very low. Several folks likened it to that first day home with a new baby of, gee, what do we do if there's a fever or the baby throws up or whatever? Without having Granny right there to kind of offer guidance, they simply were not comfortable with their level of their competency in being able to manage their rights. And I'll show here a couple of the quotes from folks that came up in the focus groups. They were basically going from an environment where we were here to support them at every turn to now being home alone without that assistance. Thirdly, patients and families all commented on the importance of peer mentoring, that this was important to their recovery once they got home, and that peers were especially useful for example, discussing very sensitive issues like sexuality or bowel and bladder management, things that they were not quite as comfortable discussing with a nurse. And then clearly there was credibility hearing this information from somebody who was going through that experience, who had had to master that problem, versus hearing it from a nurse who really had never experienced that firsthand. Beyond basic care, it was also helpful to gain insights into what do you do when you get home, and you kind of master the process of managing your care, what's next, and how do you get back to life and get on with life. And there was a very strong sense that patients and that peers should be involved in family training. Inadvertently, in expanding the hospital in the mid-2000s, we doubled the number of patient rooms that we have and went to exclusively private rooms. And in the process of doing that, we inadvertently did away with a lot of the informal peer mentoring and peer support opportunities that existed. That likely added to this kind of lack of response shift in our patients kind of getting on with life after disability. So clearly peer support needed to be one of the interventions that we moved ahead with. Thirdly, we found that our patients and families, again, our average age at admission is in the early 30s, and so these are folks that are pretty tech savvy. They're used to using the internet to access information. Many folks said that was the first thing they did when their loved one had sustained an injury. They went to the internet to try to find more information about it. So they're very comfortable using technology as a basis for gathering information, reaching out to others to kind of support that peer-to-peer healthcare experience. And there was very strong support for building a one-stop shop, if you will, portal that would allow them to access critical and credible information, but also access peers for additional support. All of these things led us to believe that a lot of the problem was not so much that we were not teaching the patients the competencies that they needed or the information that they might need post-discharge. We were just not doing a job of helping them gain the confidence that they knew what they needed to do at discharge. This concept is called self-efficacy. It is one's confidence in one's ability to successfully execute actions to achieve desired outcomes. Concept developed by Albert Bandura in the 60s and known to be a powerful mediator of self-management, used in cognitive behavior therapy and also in chronic disease self-management. And there are three strategies that we know help facilitate self-efficacy. Not just practicing skills, but really a sense that you've mastered these skills. And again, that oftentimes means limiting your focus to the set of skills you absolutely have to be successful. Modeling of desired behavior, seeing other ones who have gone through the same experience, being successful in managing these conditions and achieving these outcomes. And then social reinforcement to encourage you not only to master the basic skills you need to be successful, but to continue to improve upon your performance. And fortunately for us, in looking at possible models we could adopt in changing our practices, we ran across the work of Dr. Kate Lorig. Kate is at Stanford, and in the late 70s developed the chronic disease self-management program at Stanford, very much based on Bandura's concepts of self-efficacy. Its focus is, it's very peer-directed. All the classes are taught by peers. The focus is on helping folks gain the mastery of skills, the self-confidence that they need to be successful in managing chronic disease states. One of our big questions is, would this apply to individuals who did not have chronic disease or disability, but for whom the onset of disability was quite sudden? And so we've been working with Kate Lorig as part of our team to take some of her concepts and apply them in the interventions that we're developing. And so that's been the focus of our work. There are three primary interventions we've identified to promote self-efficacy: re-implementing a very strong peer mentoring program here at Shepherd Center, revamping our patient and family education to make it, to focus much more on critical decision making, on the 2 or 3 problems that patients absolutely need to be able to master, and incorporating peer mentoring into that process, and then creating a patient portal for both the post-discharge support that families and patients will need once they need Shepherd Center to continue to remain in contact both with our staff and also peers. These were rolled up into 3 primary aims of our PCORI grant: partner with our patients and families to develop these interventions, refine and implement these system-wide, and then evaluate the impact of these system changes on patient and family self-efficacy, ultimately on their health care outcomes and quality of life outcomes. And Julie, as part of her presentation, will kind of go through some of the research that we're doing related to that. Julie?
Thanks, Mike. And yes, I would like to take you now through the actual research grant that we have. We did get it from the Patient-Centered Outcomes Research Institute, and Mike gave you a lot of good background. We are in the midst of that grant, so I don't have any outcomes yet to report to you. So even though this is a talk about a research program, I really want to focus on implementation methodology and not so much on outcomes because we simply are not there yet. But as he said, we have 3 components of this project. I'll talk about first and probably for the shortest amount of time because that's the one that we are into the furthest. We are conducting a randomized clinical trial for peer mentoring and using control group, intervention group, and we'll evaluate outcomes for both groups. Our education programs, we're doing a trial as well, but we're doing a stepped wedge design kind of approach where we will be implementing module after module as we develop them. And then finally, I will talk about our initial steps in working through issues in developing a patient portal. These are our peer mentors. They are some of the most popular people in our hospital. We call them our pretty people. 3 of the 4 were Shepherd patients at one point. Several of them are extremely highly functional, which sometimes can be a negative, but it certainly shows what is possible. And the girl in the middle with the green scarf is actually a C5-6 quad, so she does have some hand-related issues that our other patients with quadriplegia have to deal with. All 4 of these folks feel, and the patients tell us, we like to talk to them because they speak our language. They don't speak PT language or OT language, but they help the patients take exercises and interventions that they learn during therapy and start the process of converting exercise or intervention practice into lifetime skills. And that's what people need to have because you don't go through life going to therapy, you go through life living a therapeutic life. So the way that we are trying to make that happen is the control group is receiving what we are calling our one-on-one peer support initiative, in that every patient in our intervention group does receive a one-on-one interaction with one of our peer supporters every week during rehabilitation and for 90 days after discharge. Patients direct these sessions. They talk about whatever the patients want to talk about, and the mentors are very keen on offering both emotional support as well as some physical practice of how to do things so people can eventually look forward to living a fully realized life. Our mentors are 4, however, we have many patients here, and some of our patients have needs not addressed or modeled by our 4 on-staff mentors. So we also have accumulated this group of additional people in the Atlanta community that have injuries and want to get back to current patients. We sponsored a training session with the Christopher and Dana Reeve Foundation. So we have a cadre of about 40 additional people with spinal cord injury to support our current patients with spinal cord injury in their rehab process. All of these mentors will talk about whatever the patients want to talk about, like I said, and very often it is those issues that are sensitive and can be talked about better with somebody who's had the practical experience versus a nurse, a therapist, a doctor standing next to you telling you what you might go through in the next month, 3 months, 10 years. A lot of talk about bowel, bladder, sexual issues. And then simple things like, can I go to a restaurant and how do I do that in my wheelchair? How do I pay the bill? All of those kinds of just practical day-to-day relationships are talked about. And one of the most popular programs that we've come to find is that our mentors will take a patient and a family member out to a restaurant and actually demonstrate the process and have the patient start practicing the process pretty early on in the rehabilitation period. They offer lots of tips and tricks, and these are some of the most helpful things because while there are things that are done in the Shepherd way, or what we call the rehabilitation hospital way, those have to turn into the real life way. And they're not always the same. And as a matter of fact, they're often very, very different. For example, to do a bladder program here at Shepherd, I've heard you need about 40 clean washcloths. Well, no patient is going to go home and use 40 clean washcloths every time they have to do a catheterization. So peer support really does provide that link or that bridge between exactly what is taught versus what is practical in everyday life. And they strongly believe that telling is not training. Telling ain't training. They say that in the South, but I think it's true just about everywhere, that when you can see something, it has much more meaning than just somebody telling you how to do it. Uh-oh, do we not have audio on the videos?
You have to narrate.
Well,
Do you not have any audio?
No, I hear nothing.
Oh.
Anyway, as you try to fix that process, this is our quad who is in a working situation, but she can't get paper out of a printer. She can't physically reach up there and grab the paper. So do something very, very simple to just do that. Easy, but kind of fun to demonstrate, fun to watch, and fun. You know, it's kind of a link where somebody could say, well, I could do that too. Here's another example. How do you read a book when you're a quad? Well, there's a lot of power in your spit. You spit on your finger, you can turn a page. You spit on your finger, you can also get things out of a wallet. Very helpful when you're trying to go out into the community independently and have to pay for things. How can you pick up a couple of pills and take your own medications without having somebody actually have to hand them to you or put them in your mouth? We call this a little dabble do ya, and it does go a long ways. People also have to do car transfers. There's lots of different ways to do car transfers, and this is one of the biggest issues when people are talking about going back and forth to work or back to school after injury. Some people want to break down their chairs so that they can have little tiny cars. Some people want a van because they don't want to break down a chair. There's all kinds of different reasons that go into vehicle selection, including price, but we show different ways that people do it, as well as sponsor little competitions in time. Again, and this is just to show people this is what you have to look forward to. If you want to go to work or to school or to anywhere else that you need to eventually get a driver's license and then drive, it's very practical to do it, and lots of people do it lots of different ways, and pretty much all the time. The guy in the top right, he's only been practicing about 3 weeks, and he was a person in our day program here at Shepherd, and so for him to get to this level of perfection, just 3 weeks of practice, was really quite impressive. But you can see very independently in and out of a car. And then, of course, we have a couple of guys that are, like I said at the beginning, rather functional, and they do this very quickly. Sometimes this is actually a drawback when people in the hospital see these folks actually being able to stand and to hobble walk, as they call it, because that is not a realistic expectation for many of our patients. The other thing that the peer support team tries to do is to offer a social media link where people can go to for information. Sometimes the things that you need to know to get through life are not actually taught in a rehabilitation hospital necessarily, or they are, but they're not at a level that is applicable or practical in a home environment. And when you get home, sometimes you just need to talk things through to figure out how to make things work in your environment with your peers. So we've established this Facebook page that is an invited Facebook page. It is moderated, so everything that is on there we think is appropriate. We don't control content, but we don't want anything inappropriate in there. And they address all different kinds of things. This discussion, and it's very truncated, happens to be about something we call chicken fat. And it's basically just a special type of pad that you can easily carry around in your lap or in your purse or in your bag, and to put it on your seating surfaces. Very, very helpful in preventing pressure ulcers. There's a lot of talk about pressure ulcers on these sites, what to do if you get one, how to do your pressure relief. In the hospital, a lot needs reinforcement as time goes on, because this is a condition that will never go away. You always have to manage your skin, and pressure ulcers is a very big deal in this population. So we call that little piece of plastic there on the right chicken fat. Wash and drink is another one. UTIs are one of the most common complications and certainly the most common cause for rehospitalization in patients with spinal cord injury. And no matter how many times you tell people on the front end when they're going through rehab that you need to drink and you need to be clean, it doesn't always translate into daily life skills. And so reinforcement from people in your community living with the same issues that you are. How do you do it? When do you do it? How much do you have to drink? It's so important to drink. It's important to drink, and it's important to wash. And it's important not to do things like using gloves from a dirty box that you may also be doing your bowel program with. Lots of conversations on these Facebook pages, and this really has become a source of where people go to get information rather than calling a professional back in a doctor's office or even trying to recontact people here at Shepherd Center in their months and years post-injury. There are lots of different examples. I liked this one because our patients during the summer wanted to go to the beach. Well, who teaches somebody how to go to the beach in a wheelchair? If you haven't done it, it's not, you know, a typical therapy skill. So there was lots of discussion on how to do that. Here's another video showing a woman, and this is one of our supporters, who a lot of times women want to cook dinner for their families. Can you still do that? And here's just a very good demonstration and a fun demonstration of, sure, once you're injured and you're back, you can modify your home. You can still do these things. Not having the audio here kind of diminishes the video, I think, a little bit, but Mina is a fabulous cook, and she has people over to her house for dinner frequently to just sort of demonstrate the process. She loves to cook, and lots of people like to eat. So there's dinner on the table. So that's our peer mentoring program. All of that is underway. We are looking very much forward to our evaluation measures. And at the same time, we're trying to revamp our education programs. And developing these programs may not be quite as much fun, doesn't use as much social media, but we still are trying to make these as interactive as we can and to speak very clearly to what people need right here, right now, and not give a full dissertation about spinal cord injury, what happened to you and where you need to go. We are focusing on major areas that are associated with rehospitalization, urinary tract infections, pressure ulcers, and respiratory issues. We thought we should practice on something, though, so we're also doing a module on bowel management. All of these issues do suggest problems with self-care routines, and we feel that if we increase people's confidence and their ability to manage and to deal with daily routines, that may very well influence our rehospitalization rates. People need confidence to self-manage conditions. When we asked our patients what would help, they definitely referred to this need for quick and easy access to information, and perhaps not quite as cumbersome as it was before, so we have made very dedicated use of devices that can be held in hands, whether it's a phone or a tablet device. They're easy to carry around in the chair. They fit on the lap. They go in the pockets. And they replace this monster manual that was quite heavy, and there were so many pages in it, I think 195 if I remember correctly, that people couldn't find what they were looking for when they needed to find it anyway. It was always just, oh, it's somewhere in the book. So again, we always think we can improve upon our education programs. We are using existing technology, but more importantly, we're trying to make the education focused on the patients and, again, not telling them what to do, but helping them learn what to do, and using these blended learning techniques that we did lift very heavily from Kate Lorag, as Mike was saying. We are almost completely trying to phase out our didactic lectures. We do not want people to stand in front of a classroom and talk to a group of people about how to do something. We would much rather encourage our patients to take control and to show them how to do it, and it is shown from a peer's perspective. So our peer mentors are always showing people what they are capable of doing. The blended learning approach actually does assume that patients are going to, or any person is going to take responsibility of their self, their learning, their needs, And so our approach, as is that of Kate Lorig's, is to have people watch information before coming to class. I think this is being used in a lot of university settings now. But we make educational videos with the how-tos that people watch ahead of time. And then they come to class, and the class is completely dedicated to what problems are you having around certain topics, and how do you think we can problem solve those issues. Our classes are no longer being taught by the nurse education staff. They are being taught by our peer mentors, with our educators sort of hanging in the background to answer any medical questions if they come up. But the class is all one-on-one, not one-on-one, one mentor at least with a group of patients, and very often more than one mentor, because depending on the mix of the patients in the class, we want to be sure that we have mentors who can speak the language of the people in the class. So I think on the right is more of a typical, and it's sort of a comical approach to what classes are usually taught as, where there's somebody at a chalkboard or looking at a PowerPoint talking to the students in the class, and how different that looks than the class on the left, where people of varying levels of injury are discussing what problems they have and how they can resolve those problems. Sort of a type of experiential learning. If I have this problem, what do I do? And one of the best ways to learn about it is to hear from other people who have had those exact problems. And we're doing bowel management now, so there's a lot of discussion about, oh, I had this involuntary, and boy, was I embarrassed. But this is what I had to do to clean it up, and I did, and I went right on with what I was doing. We do have one outcome that we can speak to very highly now, and that is that our patients in these classes, they're not falling asleep anymore. And we often used to have people that just went to sleep in the class, and these were not typical students. These are just people that are in pain, they're on medications, they're dealing with catastrophic injury. So how do you keep them engaged versus looking at a PowerPoint and just zoning out? And we have found this to be extremely effective in that we are able to engage them in conversation and get them to participate in problem-solving discussions. So right there, I think we have accomplished one of our biggest outcomes, although that is not one that we are technically measuring. The ones that we are measuring, we are looking at healthcare utilization post-discharge, both at 30 days and farther out down the continuum. We're also using measures of self-efficacy, depression, participation from both a chart and an injury intrusiveness scale. You may be familiar with some of these tools, and also satisfaction, both satisfaction with life as well as satisfaction with the peer-mentor interactions. And finally, once we develop these two programs, we will have lots of information and discussion forums to populate our patient portal that we are also developing, but this is very early on in the process here. We are looking to digitally enable transition experiences. We want to be able to track patient journeys through acute care, rehab, and on into life post-injury. We do want to provide a way for them to continue to have peer-to-peer support, both with our peer mentors in the hospital, but also just other people in general living with spinal cord injury in multiple communities across the country. We may have some contact with our care team members. We like people to be able to keep calendars, establish social links, and essentially just have a one-stop shop where people can go to for information, whether it's medical information, recreational information, social information, whatever you want to call it. It is a link to, or will be a link to all of those different kinds of things. We always like to think that if you're trying to be normal, you'll never know how amazing you will be able to be. Maya Angelou said that quite some time ago. And here at Shepherd Center, we know our patients will never be quote-unquote normal again. They know they'll never be normal again, but we really try to help them envision how amazing this new normal that they need to develop and be. And that is our goal. Every one of our patients has to develop what's newly going to be normal for them. And so with that, I think we are at about 10 to 15 minutes left in the presentation, and that's about what we were told to leave for questions. So Mike and I are here to answer whatever questions you may have.
Okay. Thank you very much, Julie and Mike and Julie. We'll go ahead and get started with the questions, and we'll see give people a chance to answer their questions, I would like to go ahead and start. Let's see, our first question is, let's see, okay. Let me go ahead. Actually, the first question is coming in from the chat, and it is the Facebook name Shepherd SCI Peers? The comment is she's very impressed. Never realized some of the issues post-rehab. Thanks. Great talk.
Yes, that is the name of the Facebook page. It is open for friend request only, so it is a controlled page, and our peer mentors monitor that page at least daily, so they look at all of the posts, and they want to be sure that posts are legitimate and they are from people that should be on the page. Anything that has anything derogatory, foul language, that kind of stuff, they do have the ability to remove from the page. But the other really neat thing about it is sometimes people don't want to post a very personal question next to the picture of themselves that identifies themselves. So they will send via email a question to one of our peers, and then the peers will rephrase and repost the question. And so there is a discussion about an issue, but nobody really knows who the person is that you're speaking to or who initiated the question. And that has become an extremely effective forum, especially for discussing things like there was one where a newly injured person had a spouse who wanted to be the caregiver, but the person didn't really want the spouse to be the caregiver. And what do people do about spousal relationships versus caregiver relationships and parenting relationships too? So there was a really good discussion about different options, and basically what it came down to is anything is okay, and it works differently for all, for everyone. But those Facebook pages just provide excellent forums for those kinds of discussions. And the truth is, a lot of that stuff just doesn't come up when you're in, certainly not in your trauma centers or in acute care centers, and even in rehab. You have to be out in the community living your life and trying to figure it all out. And at that time, there is such a need for this collegial support and access to information. And that's where the Facebook page has just been very, very helpful.
Okay. We have a few more questions, and I'll go ahead while we wait to see if anybody wants to raise their hand and ask questions, or if there are some more. Actually, we're getting some in through the chat. You may have covered this, Julie, in the presentation, but I thought I'd go ahead and ask it, and that is, do you have challenges enrolling patients into the trials?
I didn't address that during the presentation, but it is a very good question. And the answer is no. We really don't. The only one we've started to enroll in so far is our peer support trial. And we have had a few people decide they don't want to participate. We think that may have been our approach to having a female person go speak to a very young 18 to 20-year-old male. Just because of the sensitivity of these issues around bowel, bladder, and sexuality, that, an 18 or 20-year-old boy doesn't want to speak to a young woman about that at that early phase of injury. So we've now tried to have our consenters, because our peer supporters do consent. We wanted, again, this peer-to-peer kind of interaction right from the beginning. So we often have a male person talk to our male patients and females talk to female patients. Every once in a while somebody does decline, but for the most part, people really want peer support. They're so intrigued by the concept that they want to be part of this trial. And we pay them a little bit, $50, but it's really not much. It might be enough for some.
Talk a bit about the control group and how the interest in.
Oh, well, yeah. I mean, once they're, that's the problem, is that we have to put half of them into a control group. And once they're consented, they want it. They can, and that's one of the things that are coming up in the follow-up evaluations, is you tell us we're going to be part of a peer support study, and then we don't get any peer support. And that's been a really, really hard issue for implementation as well, because we want to provide this kind of support to everybody. We want, it's beneficial to have people be able to talk to their peers, and to hold back because they're in a clinical trial. That's a little challenging.
But I think it's important to note this is not an untreated control group. If they are randomized to control, they do have access to a lot of peer support opportunities. We have regular meetings and events that they would certainly be encouraged to participate in. And I think what we've seen since this trial started is a much higher level of participation in those events than we've seen historically.
Very true. But when people want peer support, they have to actually request it. And some people don't realize that for some time into rehab, versus if you're in the intervention group, there's no requesting going on. Somebody's at your door. And that's really the difference. But if people do request it, we do provide it. And then very often when we're thinking forward to analysis, we're thinking we may have to take some of our control group patients out of the control group simply because they've had so much intervention at their request.
Okay. I've got a couple more questions, and I'm encouraging the audience to chat in or any questions they have, or raise their hand, and we'll open up the phone line. But the next question is it unusual to have peer support be a part of a hospital staff, and how integral are they to the blended learning concept?
It certainly is unusual, although you do see peer support programs in most rehab hospitals, dedicated hospitals. And it was a concern we had going into this, just how well received turning over control to the patients, if you will, might be particularly by our education staff. And I have to say, early on, there were concerns and reservations. I know when Kate Laurie came out for a consultative visit, and she encouraged them to kind of put away their PowerPoint presentations and let the patients drive the classes in terms of the types of questions they had. There was a lot of concern about that. But gradually, staff have realized that, in fact, it does become much more relevant. Patients are much more attentive. There's a much higher level of engagement when you do that. And now that peers are actually co-teaching the classes, we found that most of the educators have a 180-degree conversion in terms of their support for that. They, in fact, do see that peers can approach things from a very different standpoint that they can. They're still the experts. They have the background knowledge as needed, but there's the credibility that the peer provides in terms of the the real importance of the information being conveyed. Would you support that, Julie, or other things?
No, absolutely. I think one of the most astonishing things for me is to see a classroom that looks like that discussion circle, and the educators are sitting in the background. I never, ever envisioned we would get to that point and get to it as quickly as we did. But educators are so on board because they see the difference in the dynamics of the group, and it's very encouraging. The other thing, too, though, is that most programs within a hospital, including a rehab hospital, are funded programs. Somebody's going to pay for that, for services from a reimbursement standpoint. Well, nobody pays for peer support. So it is an unfunded kind of department, and that's why many, many hospitals do not have staff members who are peer supporters. They have a big volunteer group that they associate with. Having 4 people on staff, I think, is incredibly unusual, because it's not a funded service.
All right. We have one more question. We'll see if we get some more, but we have one more question, and that is, how can the tips and tricks provided by support best be found by consumers?
You can certainly do YouTube searches. They're all on YouTube. They're also always posted on the Facebook pages. So that is the immediate mode of access currently. And like I said, as we develop this further for our patients, they'll also be included in their portal access via links. But for right now, they're all YouTube videos. Okay.
Well, thank you so much, Mike and Julie. I appreciate, on behalf of Project Dispatch, your presentation today. Our attendees, I'm sure, found it quite valuable. That is the conclusion of our Q&A, and I want to remind people to be looking for the save the dates on future webcasts. And with that, we'll conclude today's call. Thank you.